Good afternoon, and welcome to The Heightened State of Security, a webinar produced in partnership with CHIME and AEHIS, sponsored by Lenovo Health. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by our Managing Editor and Director of Social Media, Kate Gamble. You can participate in a separate browser or on your phone by using the hashtag HCCIO chat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, so as questions occur to you, please type them into the Q&A box, leave the default set to all panelists, and we'll take those later in the program. And you can download the deck using the URL on your screen. It's at the bottom of some of our slides, and it is being sent out in the chat box as well. Just so you see how we're going to spend our time today, first we're going to hear from Theresa Meadows, SVP and CIO at Cook Children's Healthcare System. Theresa is also the co-chair of the Healthcare Industry Cybersecurity Task Force. Then we're going to hear from Garrett Hall, Research Director of Cybersecurity and Implementation Services with KLAS. And then we're going to hear from our sponsor, represented by Tom Foley, Director of Worldwide Health Solutions Strategy with Lenovo Health. Then we'll have our Q&A. So without further delay, I'm going to turn it over to Theresa Meadows. Theresa, thanks for joining us.
Thanks, Anthony. I really appreciate it. Thanks, everybody, for allowing me to talk a few minutes about the Cybersecurity Task Force. It's been a long year's worth of work, so I hope that you find the information helpful, and I'll be open to questions at the end. Let's see.
Let me know. Oh, there you go. There you go.
There we go. We're moving now. So, you know, lots of people have asked me, you know, as a healthcare CIO for a children's hospital, why in the world would you want to participate in a task force led by Health and Human Services about cybersecurity? And this picture to me really describes the reason why. Cybersecurity has really become a patient care issue and a patient safety issue. And so I think there are things now around security that we didn't have to plan for many years ago, with network medical devices and electronic medical records now being deployed in almost all of our organizations. There's just a lot more risk around cyber than there has been in the past. And just to give you an example, this is a screenshot for one of our security monitors. And on average, we're being attacked or attempted to be hacked or attacked about 280,000 times a month. And these are the ones that we stop. And you can see a lot of them come from the United States, but a lot of them are from other countries outside the United States. And so there are always constant attempts. Most of these are automated attempts. There's not a person sitting behind the computer, you know, trying to access our systems. But there are always constant ongoing attacks. And so our security team, this is one of the things that they monitor to prevent people from the outside coming in. So if you think, you know, a pediatric hospital wouldn't be a place where people would try to, you know, engage with us or try to breach our security, absolutely. Don't fool yourself that you think that you're really secure. People are trying day in and day out to get into your organizations. And these are really some of the reasons why I put my name in the hat to be part of the Cybersecurity Task Force. You know, if you look at the charge, this is a quote by Secretary Burwell from Health and Human Services. You know, really the goal with implementing electronic medical records was that everyone should have easy and secure access to their health information in any location. And so the underlying goal for implementing electronic medical records was really ease of access and really being able to provide patient care. No one thought, as we went through this process, that we would really be opening ourselves up to risk from a cybersecurity perspective. So I'm going to do a quick overview of what the task force is and how it was formed. So it was really established about a year ago year and a half ago in December of 2015 under Section 405 of the Cyber Information Sharing Act of 2015. And really the purpose of this task force was to evaluate the risks that are unique to healthcare and then begin to recommend some best practices related to those risks. This was a time-limited task force, so we literally found out that we were on the task force in February of 2016, and we began working in March. And we're in the final stages of the report right now. We completed our very first draft in March of 2017, so just a month ago, and we hope that by the beginning of May, we'll be able to release the report to everyone, to the public and to Congress. In the task force assignment, we had some very specific things that we were asked to address as part of our end report to Congress. And the first is to really look at how other industries have managed cybersecurity and security tasks. So we've looked at energy and banking and finance and Department of Homeland Security, areas who have spent a lot of time really perfecting their security strategies. So we had a lot of best practice presentations from those areas to see if any of those things would really translate into healthcare. The second thing we were asked to do is really analyze the barriers and challenges within our industry and really document what those things are. Healthcare is a very complex industry, and we'll talk about some of the complexities in just a minute. But how does that differ from, say, banking? We had a specific charge to really look at network medical devices and biomedical devices and or any other software that connects to the electronic health record. As we begin to integrate more, as you all are well aware, network medical devices become more and more of a risk based on just how old they are, the process they use to vet their security practices. And so we came up with some specific recommendations around these particular devices and software that we'd like to see implemented in the future. And then really providing this information back to the Secretary so that they can then inform all the key stakeholders on how to improve. So there are some recommendations on, what are some just basic things people can do to improve their cybersecurity landscape. There is a request that we establish a single way to share intelligence information about cybersecurity threats in the healthcare industry in near real time and at no fee. And that's no global task, as we know. Everything has a fee associated with it. And how are we going to provide something back to everyone in healthcare that's usable and hopefully at low or no cost? And then at the end, we'll report on the A through E on this slide back to Congress. So how were the task force members selected? There were about 200 applications, and they narrowed the list down to about 20 participants. Either they had service in a position in healthcare, or the public sector, and they spent a lot of time looking at broad healthcare issues. They either had experience dealing with technical and different legal aspects in healthcare information security. They had good knowledge of policies and procedures and what's going on in the industry. And the other thing was, because we were time limited, we had to be able to participate pretty much every month on this task force to be able to get a deliverable done by the end of March. So the membership is very well-rounded. You'll see hospitals and providers represented, the pharmaceutical industry is represented, medical device industry is represented, big laboratories that are outside of a hospital setting have representation, health plans and payers have representation, and then a lot of people from health information management and medical technology. And then there's a lot of federal government counterparts from the private sector, from Homeland Security, from NIST. So there's been good cross-representation from the public and private sector on this task force. The FDA was actually represented. So they tried to match a federal counterpart with the sector representation from the private sector. So, you know, as you can imagine, our monthly meetings were pretty interesting as you start to break down all of those sectors, because there are certain things that only occur in pharmaceuticals, or certain things that only occur in device manufacturing. And what we tried to do is, you know, reduce the number of initiatives and things that would serve the community as a whole, because we could have spent a lot of time talking about IP or intellectual property security, but that really has a small subset of the total population. And so what we tried to do is really outline findings that most organizations could adopt, regardless of whether or not you were a laboratory, or you were a pharmaceutical company, or you were a hospital. As we worked on the report, we are working internally with working groups. So we divided the working groups out in these areas. So risk identification by the healthcare sector. And if some of the things, you know, when we looked at risk, there are really three or four primary things that we looked at. So data integrity. Is the record going to be changed in any way if we have a cybersecurity attack? Is the PHI protected? So are there any HIPAA implications from these risks? And so we looked at how do we define roles and responsibilities and recommendations around the different types of risks that could happen in the healthcare sector. We spent a lot of time talking about medical devices, electronic health records, and other clinical systems. There are lots of clinical systems that integrate with the electronic health record that are not part of the electronic health record, so case management systems. There are medical devices that have small EMRs attached to collect clinical data. For example, at our organization we have a gate lab. Most of that gate lab is a medical device, but there is a small EHR attached to it that actually collects clinical data about the patient, their diagnosis, their history, how they've worked in the past with their gait, what kind of medications is that patient taking. And so when we looked at medical devices, it was very important that we recommended some standards around medical device security, privacy around those devices, and how do we make sure that those devices are kept secure and accurate. We spent a lot of time, and you'll see recommendations in the report around workforce capacity and shortages. As you well know, it's very difficult to find cybersecurity professionals, and if you do find them, it's very hard to afford them. So what are opportunities for, you know, smaller organizations for a, you know, 10-dot practice or a 2-dot practice to have the same level of security that a big hospital would have or a pharmaceutical company? And so looking at making some recommendations about how to train the workforce, how to share workforce opportunities, and maybe some, you know, potential business ventures that people can go into to be able to provide support in areas where you won't have those security professionals. We spent some time talking about sharing cybersecurity information, and if you know, there's a lot of organizations today that will assist you in sharing this information. You may have heard of the Information Security Organizations, or the NHISAC. Those organizations actually received a grant to begin looking at how they could begin sharing information across the industry. What we found is there are very few members in these national healthcare information security sharing organizations. And part of the reason is there's still a concern that if we share security information, that there may be some HIPAA breach or those types of things associated with it, so people don't like to share. And so we spent a lot of time talking about how cybersecurity information can be shared without breaking any of the HIPAA privacy laws. And you'll see some recommendations in the report related to that. And then the last really is about each organization individually. Do we have the appropriate leadership, and are they educated? Are our boards educated on the appropriate things to do from a cybersecurity perspective? And do we have governance structures in place that allow us to assess risk. And then, are we following any types of standards? There was a lot of discussion in the group about what standards should be used or recommended for organizations to follow related to cybersecurity and security threats and risk assessment. And you'll see in the report some of the recommendations that we're making around standards and the standards organizations that people should consider reviewing and moving that forward. And, you know, I think part of the reason why I'm being a little bit vague about what's in the report is that I unfortunately, because of the law, cannot speak to the report, any specifics in the report until it's released publicly, which we hope will be in May. But you will absolutely see in the report lots of information around risk identification, medical device security, maybe some suggestions around how organizations should begin developing their risk profile. If organizations on this call, the one thing I would say is the first step in cybersecurity is understanding the risk that you have in your organization. If you haven't been through a good risk assessment around cybersecurity, that would really be the first step that I would recommend, because until you know what your opportunities are, it's really hard to mitigate security issues. And from a cybersecurity perspective, it's not if you'll be attacked, it's probably when. And so having those mitigation strategies and then having good recovery plans in place when a situation occurs. And the things that you see in the media, it's because those two things did not occur. They did not have a risk assessment most likely, and they probably didn't have a mitigation strategy so that they were able to recover quickly. And so those would be some of the recommendations from a leadership and governance perspective, that if you had to pick a thing to do in your organization due to limited funds or resources, that's where I would spend the majority of my time initially, is really looking at what my risk is and how do I mitigate it. And then you can always, over time, begin to build your plans in place to get you in the right direction. Because you can't, security is I always say it's a lifestyle. It's not a project or a single implementation. It's really a way of life and how you choose to protect your organizations. And so I would recommend really spending some time in your organizations looking at the risk. So process on the final report creation. You know, we are required to absolutely report on the sections A through E that you saw on the slides earlier. So we're in the process of mapping imperatives, recommendations, and action plans to each of those 5 items. We're identifying some best practices in each area, and then if there were things that were applicable in other infrastructure sectors like energy or banking, we're noting those. And so some of the good best practices, if you look at those other industries, were around how they shared information and some of the requirements they put in place. And so you'll see that in the report. There's definitely a lot of documentation about some of the gaps and challenges, but for most people on this call, you know what those are. We have limited funds, we have limited resources, and how do we deploy the best resources at the time that we need them? And you'll see action plans and recommendations around continuing this work, because of the time limitation, we're not able to implement anything. And that really was probably the biggest frustrating point for this task force is it's great to make a bunch of recommendations and hope that those things happen. So our biggest recommendation is that we have some way to carry on the recommendations and into some implementation timeline and format, because I think that's really the end goal is how do we implement some of these things so we can actually improve cybersecurity as a whole across the industry. And I hope that, you know, the work that went into this report is carried forward. That would be our number one recommendation is please have a way to carry, you know, some of this work forward so that we can continue the momentum that we have. And I really, you know, would love in May timeframe to talk more detail about the recommendations once I'm allowed to publicly. But I will definitely open it up to questions at the end if there are questions, and if I can answer them, I absolutely will. And now I'll turn it back to Anthony.
Very good, Theresa. Thank you so much for that presentation. We're looking forward to you getting back with us during the Q&A. Okay, now it's time to hear from Garrett Hall, who's a research director with KLAS. Garrett, thanks for joining us.
Thank you, Anthony, and it's a pleasure to be here to share some of the research that KLAS is doing. Loved hearing from Theresa and the work that the task force is doing. I think that hopefully our research contributes to solving some of the problems and issues that we have in cybersecurity and healthcare. A little background on KLAS in case there are some who aren't familiar with us. We do research in healthcare specifically. We work with providers to understand who they're using in different areas, different vendors, and then we get ratings, and we kind of view ourselves as the Consumer Reports of healthcare IT, trying to bring more transparency to the industry to help providers make more informed decisions. As part of that, we've measured EMRs and population health and areas like that for many years. Cybersecurity is kind of a newer area for us, and part of the reason, Theresa touched on it, is that before it was hard to get people to talk about their security programs and what they're doing, and now we're encouraged by some of the momentum that we see and people willing to discuss some of the issues that they're having, some of the best practices that they've found. And so it's really helped our research as we launch into this massive area to have provider participants in our research. One thing I should also mention is that we partnered with CHIME on this report. They were a great partner and helped really get the word out and get people to participate, and then to really let everybody know about the research and some of the findings. So we look forward to working with them more going forward. So as part of this research, we spoke with about 200 different organizations, and one of the things that KLAS typically does in these reports is we try to differentiate vendors. We find out what strengths and weaknesses they are, what capabilities they have, and what they're doing in various areas. And we did that in this report, but we also saw that there was a need for just kind of an industry landscape, kind of a benchmarking to see where providers really are. And so we asked providers questions about their own security makeup and how confident they are in their security program. And so one of the questions we asked was just about the status of their security program. And as you can see from the slide, about 16% said that they felt like they had a fully functional security program. 41% said that it was developed, starting to function. Another 43% felt like they were just now developing or not quite developed. So that's a pretty big percentage there, about 84% saying that their security program is not fully functional. Not a huge surprise, but it just does kind of drive home where we are in cybersecurity and healthcare. We are a bit behind other industries, or significantly behind in some areas, but as part of this research, we did see some pretty encouraging signs that cybersecurity is becoming more of a topic of conversation in board meetings and between organizations. And so I'll share some of that as we go through. We asked who's in charge of, who at the organization is in charge of the security program. About 42% said that they have got a VP or C-level. Of that 42%, in about 65% of cases, it was a CIO who was in charge of the security program. And if it wasn't a CIO, then it was typically a CISO or a VP. Obviously, we're seeing more CISOs at some of the large organizations, mid-level organizations. But you also see that the other makeup is that director, manager, and analysts are in charge of security programs at many of these organizations, which is a big challenge considering all the other responsibilities that people have. In many cases, they don't have a dedicated security professional. It may be an IT director who's doing other things but also handling security. So that was a little bit sobering as well, just to see some of the gaps there. And Theresa touched on some of the reasons, I think, with resources and with budgeting being an issue there. One of the other questions that we asked providers was to just let us know what percentage of the total IT budget is dedicated to security. And the largest portion is under 3% of the budget. We didn't ask this question 2 or 3 years ago, but I suspect that if we had asked that question 2 or 3 years ago, it would have been somewhere around 50 to 60% would have been under 3%, or maybe up to 70%. So as we had these conversations, it became apparent that more money is being allocated to security issues, to security resources, which is an encouraging sign. We obviously would like to see that more and more. In some of the other industries, a huge portion of the budget goes to security. With healthcare, a lot of these hospitals are just on tight budgets, and they just can't dedicate those kinds of resources. But it is an encouraging sign that we think that, based on our conversations, that more money is being allocated and more attention is being given to security issues. One of the other questions we asked was just which security framework organizations are using. As you can see, NIST was mentioned most often, followed by HITRUST and some of the others. This is not an endorsement of any of those frameworks. It's just to let our provider friends know, here's what some of your peers are using. Here are the different frameworks that are available. And in the report, we've got specifics on some of the strengths and weaknesses of the frameworks and how confident providers felt that using a given framework or another contributed to their security health. Trying to get an understanding of what the breach readiness levels are out there. Fairly encouraging that a lot of organizations do have cyber liability and breach insurance in place. Most organizations have a breach policy and playbook created and have a breach incident team created. Obviously, we'd love to see those levels higher as threats continue to present themselves. We hope that organizations understand that regardless of what resources they have in place, that they really need policies and playbooks created and to have a breach incident team created in case they are breached and they need to respond quickly. We asked providers how they detect and respond to attacks. And you may have noticed the N in some of the other answers. There's about 170-ish on some of the others. And for the detection portion of this question, we got 46 responses. In the how do they respond question, we got 64 responses. So that means that the majority of providers that we interviewed either couldn't answer the question or they don't have anything in place to detect security attacks, and they don't have something in place to respond, which obviously is concerning. Detecting and responding is a huge part of cybersecurity. Understanding vulnerabilities through assessments and through things like pen testing are very important to prepare yourself for attacks, but it's also incredibly important to be able to detect those attacks through some tools, and then to be able to respond to them to limit the damage that might be caused by a security breach. Again, this is just information that we gathered from providers that we hope, as we aggregate it from all these different organizations, we hope that this will help those providers who read the report to say, wow, I don't have anything in place for SIM, or I don't have an incident response team put together. Perhaps we need to look into that and develop something. And so our hope here is just to educate and inform and help providers understand what some of their peers are doing that has been successful. And obviously the report that we published about a month ago, it's about 250 pages. and it's got a lot more detail on some of these areas that you can really drill down and find out what some of the providers are using. We asked providers what they're doing to secure endpoints connected to the network. A lot of different solutions here, encryption, antivirus, malware, MDM, all came up as solutions to securing endpoints. As I talk to CISOs and CIOs who are in charge of security program, this is a huge issue, and it's not going away. And so some of these solutions are really helping to prepare providers against attacks and to secure those endpoints so that they can protect the PHI and PII that is within the network. When we asked what they're doing to detect and respond to phishing, ransomware, and denial of services attacks, again, a lot of different approaches. SIM came up quite a bit, intrusion detection, end user reporting. So obviously there are a lot of different approaches, different tools. I would say that as we have these conversations, the most important thing is that there are a lot of tools out there, but just throwing tools at a problem is not necessarily going to make you more secure. The tools need to work together. Someone needs to make sure that the tools are working and that there's overlap between them. And ultimately, regardless of the tools that you have set up to help protect you, employees and training is really the key issue. Because if somebody clicks on something they're not supposed to, no matter what tools you have, that's gonna create a vulnerability. And that goes to the next slide. How often do you conduct an external risk assessment? Again, we don't have data to go back and look at 2 or 3 years ago, but I suspect that it would have looked a lot different than this. We find that 64% of the organizations that we spoke with are doing an annual risk assessment, and some are doing more often. But even the 15% that do it every 2 to 3 years, and the 9% that have never done a risk assessment, that's extremely concerning. Those risk assessments, and there are varying degrees of risk assessments, but based on our research, we've just found that doing that risk assessment at least annually is incredibly important, and it's really should be really the minimum that organizations are doing. So hopefully that number increases as providers start to understand more of some of the options out there. And we do have a section in our full report that talks about some of the firms that are out there doing risk assessments for providers and how they perform. When we asked providers to identify the 2 most impactful security vendors, the areas that they provide services in ended up being firewall and antivirus were the 2 main areas that were having the most impact, which was quite surprising for us. We were expecting some of the more advanced technologies to be the most impactful, but when firewall is mentioned more than any other technology, it was a little puzzling. It identifies, I think, how far behind healthcare is compared to some other industries. And so we see a lot of room for improvement. We'd like to see more detection, more response tools that providers are utilizing. So one of the takeaways from the report is healthcare is behind on cybersecurity, which I don't think is a shock to anyone. We've got some specific areas where we've identified how far behind we think that generally the industry is. But I would say the most encouraging thing is that it is becoming more commonly discussed in board meetings. There's more dialogue, more sharing of information, of best practices, and what providers are doing for their security programs. So I think that the reality is we've got a long way to go, but the hope and the encouragement is that we are seeing movement, and we hope that it just continues to increase, and we see more movement, and we hope that our research can be part of that process to improve the security profiles of organizations out there. I mentioned the large report. If you're a provider, you have complimentary access to that report. We hope that you'll utilize it, and that will be a help to you and your organization. If you'd like, if you don't have access and you'd like to get access, feel free to email me or give me a call, and I'd love to help you out and get you access, and then answer any questions that you have about the research. So with that, I will turn the time back to Anthony.
Very good, Garrett. Thank you so much for that great presentation. We appreciate it, and again, looking forward to the Q&A. Now it's time to hear from our sponsor, represented by Tom Foley. Tom, thanks so much for sponsoring, and thanks for joining us today.
Anthony, thank you very much. I appreciate the opportunity as well to speak to your audience. And I promise you I will not give the classic commercial, although I will talk a bit about what Lenovo Health is doing in this very critical area around cybersecurity. So Lenovo Health, just as this will probably be the only commercial slide, if you will, but this is kind of our strategy and our solution roadmap in a slide. We focus on the administration side, looking at health safety identifiers, payment fraud, digital signage. We have very specific solutions coupled with our partner network that focus on what happens in the room, the patient room, the exam room, and things of that nature. And then we certainly have a very robust portfolio about virtual care, whether it be remote monitoring, telehealth, as well as integrating Amazon Alexa into several of our solutions. But at the end of the day, everything that we do is really focused around cloud, security, manageability, mobility, and certainly coupling accessories and services around that. But let me get back to the very important topic at hand here, and that is around cybersecurity. We look at it a bit differently. Certainly, cybersecurity is critical. I want to come back to a comment that Theresa made in a very opening slide. She indicated that cybersecurity is a patient safety issue. Could not agree more. I want to dive a little deeper in that and say that data integrity is ultimately a patient safety and a patient care issue. And our point there being is that the security in and of itself is not just a cybersecurity challenge within health systems. And when we say that in the context of, look at the number of breaches that have taken place in the last couple of years. And our position is that they take that data from the back end of the health system and they walk into the front door with it. And that's where security is equally vulnerable. Medical identity theft, as an example, is an $84 billion a year problem just in the U.S. So, and the whole intent is to take that data on the backside through a security breach, walk into the front door, and have an imposter ultimately mimics another person's identity and obviously to receive care. Well, what happens when that data gets merged with the actual patient? I go on the one side of town, my imposter goes on the other side of town, but ultimately that data gets merged into an HIE or even into the same healthcare system. And then now my data the integrity of my data is impacted. And so we focus very much on that particular challenge. Another big challenge relative to data quality and data integrity is really around duplicate records. So on average, an EHR, regardless of flavor, has about 10% duplicate records. And when we talk to healthcare systems around how they manage that challenge, we actually had an ACO in the Northeast that thought that they had 7 million managed lives. And this is an ACO. They're at risk here financially about how do they manage their overall population. They thought they had 7 million managed lives based on the number of records that they had in their system. And it turns out after analysis they only had a little over 6. So when you're trying to move your population to another degree of wellness and you have 1 million patients sitting stagnant, if you will, not moving at all, that's going to put your overall health system at financial risk as we move to a value-based care model. But equally important on the duplicate records issue, a lot of health systems talk about doing a manual data reconciliation. They have an IT algorithm that in the back end, they look at 2 data records and they say, well, these should be merged. But how do you know? From the perspective of medical identity theft, how do you know that actually took place? The whole intent of medical identity theft is to mimic someone to its nth degrees to access care. So I always say that manual data reconciliation in the back end is actually a bad practice. And then certainly you go over to payment fraud, another equally challenging situation in healthcare. So ultimately what we do is we talk about having a unique health safety identifier that allows you to have a single identity. How do you identity proof, not just taking a look at someone's driver's license or insurance card when they come in? You have to do, in my view, we have to trust but verify in the context of, yeah, that picture does look like you, but in the case of medical identity theft and how that data, how they, the tactics that they use, you want to be able to specifically identity proof a person according to a NIST level of assurance 3 criteria as best you can achieve that particular criteria. Certainly there's level of assurance 1, level of assurance 2, and higher than 3, but but at the end of the day, identity proof that person first and foremost. Assign them a unique health safety identifier and allow them to take that identity across the continuum of care regardless of the EHR to mitigate, or actually we talk about eliminating duplicate records, eliminating medical identity theft, and eliminating payment fraud. So we want to protect the back end on the cybersecurity front, but you also want to protect the front end as well. And the more that you eliminate duplicate records, medical identity theft, and payment fraud, the greater the integrity of the data coming into the system is, and it also prevents other misuse of data across the continuum of care. So ultimately, we look at the ability to establish that one patient, one identity, one record mantra, again, across the continuum of care to ensure the data integrity and to mitigate any misuse of data that might have come through the back end of the healthcare system. So Lenovo offers a program that's referred to as AMI, Authoritative Identity Management Exchange, allows a person to establish, once they're identity proofed, assign them a unique health safety identifier, link that to their health records, so only they can use that health record. A lot of hospitals go about assigning, they do biometric reads, but they do a biometric read without identity proofing the person. So if you have a duplicate record, Tom Foley comes in and says, hey, that's me. Let me put my biometric down, if you will, palm vein, if you will, fingerprint, and then they think that they're off and running secure. But another Tom Foley, and the real Tom Foley, comes along and says, no, take that other duplicate record that you have and assign that one to me, and I'm going to give you my biometric. So you really haven't solved any problems. You have a false sense of security in the context of feeling like you're collecting biometrics, but you're actually collecting a biometric of someone you never identity proofed to begin with. And so identity management and data integrity ultimately starts with a NIST level of assurance identity proofing process, and then the mechanisms of how you go about validating that same identity each time they enter a healthcare system. Either they enter the brick and mortar of the healthcare system, or they also enter a virtual care setting that you also want to identity proof and ensure that you have, again, one patient, one identity, one health record across the continuum of care. So with that is really a lot, very core and essential part of Lenovo Health's efforts and focus in the data security, data integrity arena within Health IT. With that, Anthony, I'll pass it back over to you.
Oh, great. Thank you so much, Tom. We appreciate your participation and your sponsorship today. Now we have some time for our Q&A. So go ahead, send your questions in the Q&A box. Leave the default set to all panelists, and we'll take a look at those. First question that's come in from the audience for you, Garrett. What was the definition used for risk assessments?
You know, that's a good question. It's a great question. One of the things that we had to do in this research is we didn't define some of these areas for the provider because there are a lot of different ideas of what a risk assessment is. We try to collect as much information as possible, and then we do break it down. So I don't have a specific definition, one definition that we used in the report because there are different levels of risk assessments. So, but we do break it out in the report to say, you know, here's kind of a minimal risk assessment. They're just so varying. Just like with other areas like DLP, we asked, what are you using for DLP? We got some answers that we don't consider to be DLP, but we included it in the report because we hope that some other provider might say, well, that's what I use, and just try to be as broad as possible in the information that we included, but then also kind of break it out and narrow it. So I don't have one definition for risk assessment. In the report, we do provide different examples of what a risk assessment looks like on the different levels. So I'm sorry to be vague on that, but we can't really just pin ourselves to one definition there.
Okay. Okay, very good. Yes, go ahead, Theresa.
I was going to say, if I could add to that, so as part of our assessment process when we were looking across industries, what we found, which might be a bit of clarification, I don't have statistical analysis on this, but most of the organizations that we talked to, their risk assessment consisted of what was required for meaningful use. So it was really the EHR HIPAA risk assessment, and what we found was those risk assessments really weren't all-encompassing of cybersecurity. So they really met the bare minimum. So that may be why, you know, when the number looks higher, yes, they're doing a risk assessment, but it's the risk assessment that's required for meaningful use.
Very good. Tom, why don't you weigh in on the idea? So everyone's talking about the importance of a risk assessment. We're talking about basically, when we talk about a risk assessment, we're talking about getting an idea of where we stand versus where we should be, and then we come up with a mitigation plan or remediation, whatever you want to call it. So we have to figure out where we are versus where we should be, and then how we're going to get to where we should be. This sounds like pretty basic stuff. What are your thoughts?
Well, cybersecurity can be a very complex process, I would agree. I mean, the assessment in itself might sound simplistic, but many different elements, only because of the overall complexity of the health IT ecosystem that a hospital employs. It's not just about the EHR, but, you know, all the other systems that they have in place, and we're not yet there relative to a very tightly integrated platform, and I think that's one of the reasons why we have such a complex security mechanism, if you will, and maybe one of the reasons why there might be more challenges on the cybersecurity front than normally necessary when you look at the maturity of health IT versus the maturity of the financial network. I think it's just a growing pains issue. I mean, again, just think about it. You know, it's only 7 years, frankly, since health has really adopted IT and its full-blown infrastructure. You know, 7 years ago, 8 years ago, only 25% of hospitals had an EHR. Everything, we were still paper-based.
Right.
So again, it just becomes a very challenging it's a more maturity issue than growing pains than anything else, in my opinion.
Theresa, what do you make of the fact that some folks have not gotten risk assessments done? Is it just they haven't gotten there yet, or is it I don't want to know how bad things might be, so I'm just going to pretend everything's okay?
Yeah, you know, I'm an eternal optimist, so I hope it's, you know, us not putting our head in the sand and hoping that everything's okay. I mean, I think a lot of it is about organizational priorities and funding and those types of things and the appropriate resources. So, for example, you know, most organizations have a really good risk assessment probably need to outsource that to somebody outside their organization, and so which then leads to funding and those types of things. And so I think a lot of it is just around funding and prioritization and just a lot of education at the leadership level to understand why spending that money is important. And I think that's where the gap is, especially when you get into smaller organizations where, you know, they're looking at funding, you know, do I buy new beds or do I do a cybersecurity risk assessment? And so there's a lot of those types of give and take in healthcare organizations. But I think as boards get more educated and executive leadership becomes more educated, I think they will see the value in having that risk assessment done. But I think it's just we're in an ongoing education process at this point.
Very good, very good. Tom, you know, you develop solutions for hospitals to use in security. You know, there's a sort of an old joke that the people are the trouble. If the people didn't need to use the system, then everything would be fine. So talk to me a little bit about that balance between usability and security. You can lock something up so tight that no one's going to use it.
Well, that is so true. You want to have confidence, build confidence in the overall ecosystem, the security ecosystem. I'll use the example that I mentioned in my presentation. You know, collecting biometrics of your patients to validate that they are who they say they are when they come into the system. It gives some comfort, but it's not necessarily a full-blown. It doesn't give you resolution relative to the reality of knowing who truly that person is. There's a process. There's a combination of a process and technology and people that have to have this balance, and we need to be able to think through. It's one thing to have a solution, but think through the pros and cons of that solution and what holes might we open up or we might make tighter. But again, I think you're right in that the easier that we make it for access, but frankly complex relative to the systems on the back end are, you know, again, just a balancing act that we need to play. I don't know if I've answered that question quite thoroughly as I would have hoped, but you know, and the point there being is cybersecurity on the back end is a very complex and rigorous task, but you don't necessarily have users. You don't want users interfacing with that, right? Because you want to prevent them from coming in. But at the same time, if I'm logging into an EHR, I want to be able to do so, but do so with confidence and with relatively ease of use, so that we could, you know, so we're not spending 10 minutes logging in and only having 2 minutes left in an average patient encounter, right? So it's got to be rigorous, but thorough and very intuitive and quick at the same time.
Theresa, I'm going to give you the last word. If you want to jump on that, you're the one dealing with those physicians and those clinicians and everyone else that has to use that system, and they know where you are, they know where your office is, and I'm sure they're not shy about telling you when they're not happy. So tell me your thoughts around balancing usability and security.
Yeah, it truly is a balancing act, and you know, I think this is where technology can really be helpful if we deploy the right mechanisms. So, you know, use of single sign-on, use of some of the active roaming, and, you know, making security more part of the workflow and less as an additional step. And so, you know, I think as technology improves and as this issue continues to be researched, we will see improvements. You know, many of our physicians today are able to access the chart quickly and securely by using, single sign-on. And so I think deploying some of those protections are ways you get buy-in from the clinicians. So when you offer something that's a little less palatable, they're more open to considering the options. But it really is a give and take. And sometimes you can't, have a secure way to access the system. So those are systems that you would segment off your network into a very small network so that they can't infect the rest of your network. So there's a lot of technology solutions today, but it is still pretty immature. I think Tom said that the best. It's a work in progress. But I think as we learn more and we begin to, look at other industries, I think there are ways to streamline that security process as part of the workflow versus an added step.
Very good. Definitely a balancing act and a work in progress. Those are some of the key themes today. Well, that's about all we had time for today. When you close out your WebEx window, you'll be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. For those of you with continuing education interest in today's event, attending our events gets you one CEU towards the CHIME CHCIO program. So let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when this event has been posted to our YouTube channel. If you'd like us to produce a webinar for you, you can contact Nancy Wilcox, and you can go to our website to view our upcoming schedule. So I want to definitely thank our speakers, Theresa, Meadows, Garrett Hall, and Tom Foley, and I want to very much thank Lenovo Health for sponsoring today's event and making it possible, and I want to, of course, thank you, our attendees. Once again, thank you to everybody, and have a wonderful day. Take care.